All right, chapter 34 talks about the interpretation of periodontal disease, otherwise known as gum disease. This is chapter 34 of your dental radiography textbook. What will be doing is defining key terms dealing with periodontal disease. We'll describe what healthy periodontium looks like. We'll briefly describe periodontal disease. We'll discuss the importance of the clinical examination, also the dental image examination, including different techniques used. We'll describe the limitations of dental images in detection of periodontal disease and the type of dental images that should be used to document periodontal disease and the preferred exposure technique. We will also state the differences between horizontal and vertical bone loss, as well as the localized bone loss versus generalized bone loss, and also state the differences among mild, moderate, and severe bone loss. We'll list the American Dental Association's case types and describe the corresponding appearance on the dental images and recognize the ADA case types on dental images. We'll list the predisposing factors for periodontal disease and recognize and describe the appearance of calculus, otherwise known as tartar, on dental images. So the purpose of this chapter is to introduce the dental radiographer to the description and detection of periodontal disease, and to present the image interpretation of periodontal disease with an emphasis on a description of bone loss, ADA case types, and identification of predisposing factors. Dental images play an integral role in the assessment of periodontal disease. So talking about the different parts of the periodontium, remember periodontium means the supporting tissues of the teeth, like the gums and the bone. And one of these parts is called the lamina dura. And this appears as a dense radiopaque line in healthy teeth. The alveolar crest is about 1.5 to 2 millimeters apical to the CEJ of adjacent healthy teeth. In anterior teeth, the alveolar crest is pointed and sharp and appears to be very radiopaque. In posterior teeth, the alveolar crest appears flat and smooth, and it's a parallel line. It's parallel to a line between the adjacent cemento-enamel junctions, or the CEJ. It appears a little less radiopaque than in anterior teeth. So looking at your book, figures 34-1 through 34-3, we see here what the some healthy alveolar crest looks like. This is a periapical image taken of the lower right posterior teeth. So this is from teeth numbers 28 through 31. And we can see that that alveolar crest is about 1.5 to 2 millimeters apical. So that means below the CEJ. Remember, the CEJ is the cemento-enamel junction, or the junction between the enamel, or where the enamel meets the cementum. So here's a CEJ here, and healthy alveolar crest is no more than 1.5 to 2 millimeters apically of that. So that's where that bone line that you see here is. So in this individual, that alveolar crest is very healthy. Here we can see in an anterior view that CEJ is about 2 millimeters below the alveolar crest is about 2 millimeters below the CEJ, and the alveolar crest appears pointed or sharp. That's what we like to see for anterior teeth. Here is a bite wing representation of the patient's right side. Once again, we can see the alveolar crest is no more than 2 millimeters apical to the CEJ. The CEJ is here, some healthy bone level here. Same thing up top. The CEJ is up here. This patient may be experiencing very, very slight bone loss on the top teeth here. You can see the alveolar crest is a little bit more than 2 millimeters apical to the CEJ, but not very much, not enough to determine that this patient has any periodontal disease or bone loss. So just describe other parts of the periodontium. So talking about the periodontal ligament space, or the PDL. So this appears as a thin radiolucent line between the root of the teeth and the lamina dura. It is a continuous line around the root structure and a uniform thickness in healthy teeth. This is what they're talking about here. If you follow the root structure all the way around the teeth, we can see this dark radiolucent line that goes all the way around the tooth. So it's a continuous line and it should be of uniform thickness. And a healthy individual, there is no widening of the PDL or the periodontal ligament space. It's a very nice uniform line that goes all the way around the tooth. Remember, this is the mental foramen, not to be confused as any type of lesion or infection that is supposed to be there. So this is figure 34-1. This shows some healthy alveolar crest, normal lamina dura, and the periodontal ligament space on a periapical image. So that lamina dura is this radiopaque line. So this is outside of the edges of the periodontal ligament space. The lamina dura is dense cortical bone that kind of encapsulates the tooth structure here. And we like to see that line also a uniform thickness all the way around the tooth. So periodontal disease is a group of diseases that affect the tissue around the tooth. This may range from a superficial inflammation of the gingiva or gums to destruction of the supporting bone and periodontal ligament. The gingiva will appear swollen, red, and even bleeding with soft tissue pocket formation. So if you take a look on your book on figure 34-1, back over here, this is what healthy teeth looks like. Once again, so we're going to go back forward one slide. Periodontal disease, you'll see the image will look a lot different from this picture here. The alveolar crest will appear indistinct, so we won't be able to actually see where it ends, or it'll look very odd. And there, the bone loss, if you see indistinct alveolar crest, that is when that patient has considered to have some bone loss. And we'll go over some examples of those in a minute. So detection of periodontal disease can be done through clinical examination as well as a dental image examination. Dental images must be used in conjunction with the clinical examination. Detection requires both clinical and dental images. The clinical examination provides some information about the soft tissue. The image examination provides other information about the bone. So clinical examination provides information about soft tissues, whereas dental images permit evaluation of hard surfaces, such as bone. The clinical examination must be performed either by the dentist or the dental hygienist. Should include an evaluation of the soft tissue for signs of inflammation, such as redness, bleeding, swelling, or even pus. A thorough clinical assessment must include periodontal probing. So whenever clinical evidence of periodontal disease is present, images must be exposed to obtain maximum diagnostic information. With a dental image examination, this provides an overview of the amount of bone present. It'll indicate the pattern, the distribution, and severity of bone loss if it is in fact evident. The periapical image is the image of choice for the evaluation of periodontal disease. The paralleling technique is a preferred periapical exposure method for demonstrating anatomic features of periodontal disease. This is because the paralleling technique gives an accurate representation of the tooth as well as far as its size and proportions go. Using a bisecting technique will not give accurate information, and you might get some level of distortion relating to elongation or foreshortening. And those type of images may appear to show less bone loss than is actually present. So the paralleling technique accurately records the relationship of the height of the crestal bone to the root of the tooth. So if you can't get an accurate paralleling technique, the other technique that is preferred is called what's known as a vertical bite wing. We haven't taken any vertical bite wings in class. They've all been horizontal, but you will see some examples in a few minutes of why vertical bite wing is needed for a periodontal patient. So here are some images of some evident bone loss. And here we can see that alveolar crest is well below that CEJ. So this patient is experiencing some vertical bone loss. Looks like we have some furcation involvement here. Here is a paralleling technique image. And here we can accurately see the height of the bone tissue or structures that are surrounding the tooth. We have some very clear vertical defects here, lots of bone loss in these areas in front of and behind these molars. This patient has a pretty severe case. The horizontal bite wing has some very limited value in the detection of periodontal disease. This is because severe interproximal bone loss cannot be adequately seen on a horizontal bite wing. For this reason, the vertical bite wing can be used to examine bone levels in the mouth. Just to let you know, also, the panoramic image has little diagnostic value in the detection of periodontal disease. And this is because of some of the distortion that we can get with some of those extraoral images. So if you look on figures 34-6 and 34-7 of your book, we get the following images here. Here is that same paralleling bite wing, actually. Yes, this is that same image here. We can see some very distinct levels of bone. Here we have a vertical bite wing. Okay, this patient has some very severe bone loss. We can actually see radiographic tartar or calculus in these areas here. So with this vertical representation, we can see the actual height of the bone. Okay, for patients that have a severe case like this, if we were to have taken a horizontal picture, the edge of the picture would not capture the height of the bone. It would go just a little bit above that height of the bone. So we would actually just see teeth that looks like they're floating in space. Okay, so without a vertical bite wing, it would be almost impossible to distinguish that or distinguish the bone level or get an accurate representation of bone for that patient. So images alone can't be used to diagnose periodontal disease. They do not provide information about the condition of the soft tissue or early bone changes. They are two-dimensional representations of three-dimensional objects. Here also the buccal and lingual areas may be difficult to evaluate just because they're superimposed on each other. And bone loss may be difficult to detect in furcation areas. Remember that furcation area is where the roots split and go into several different roots. So if you look on figure 34-8 of your book, which is this image here, we can see some furcation involvement here. And this is when the height of the bone has gone below the furcation level. Here, bacteria can very easily get underneath this area of the tooth. And patients cannot reach this with any instruments that they have. We can barely reach it with the instruments that we have in the office. So usually when the bone goes far below enough that furcation area, the prognosis of these teeth, or especially of that tooth, is not very good. That patient can expect to see some continuous bone loss or exacerbation of the issue. These teeth will eventually become very loose or mobile, and will at some point have to be extracted. So the dental radiographer must be familiar with the appearance of dental disease or periodontal disease. Here we'll talk about bone loss, the classifications of periodontal disease, and some predisposing factors. So all images should be evaluated for bone loss. They should also be examined for predisposing factors that may contribute to periodontal disease. And these can be like age. There is a genetic factor. Periodontal disease does run in the family. Patients that don't floss or don't regularly see the dentist may also be predisposed to periodontal disease. Bone loss can be estimated as a difference between the physiologic bone level and the height of the remaining bone. This can be described in terms of the pattern, the distribution, and the severity of loss. An image allows the dental professional to view the amount of bone remaining rather than the amount of bone loss. So here we see a picture of a representation of teeth and the periodontal areas. Here, the physiologic level of bone, or where the bone should be, and this is 1.5 to this is about 1.5 millimeters below that CEJ. That's where it should be. Okay. Here we would see the height of the remaining bone. So the level of bone loss would be the difference between the height of the remaining bone and the physiological level of bone, which is where it should be. The pattern is described as either horizontal or vertical. With horizontal bone loss, this loss occurs in a plane that is parallel to the CEJs of adjacent teeth. Vertical bone loss is when the loss does not occur in a plane parallel to the CEJ of adjacent teeth. For example, this bone loss here is parallel just because if you look at the height of the bone here, it is parallel with the level of the CEJ. So that is what we would call horizontal bone loss. Here is another example of that here, a bone loss here. The CEJ plane is this area here, right where the enamel meets the cementum. So if we have a parallel line of remaining bone, this is what's known as horizontal bone loss. Figure 34-13 in your book shows a representation of what vertical bone loss looks like. If we see the height of the remaining bone here, this is not parallel, or this line is not parallel to the CEJ level here. So for a representation like that, this is known as vertical bone loss. Distribution is described as either localized or generalized. Localized only occurs in isolated areas or areas that are less than 30% of the mouth. Generalized occurs evenly throughout the dental arches and is usually more than 30% of the mouth. So for example, this is localized bone loss. For the most part, this patient is relatively healthy. They have some nice healthy bone levels throughout the entire mouth. But here they might have a little problem here. There's a localized bone loss here. It's less than 30% of the mouth. And just some areas that need attention. There could be several reasons for this. There could be an ill-fitting crown in this area. There could be things that this patient keeps getting stuck here. There can be open contacts, which create a food trap. Anytime you have a food trap in the teeth, that creates areas for bacteria to accumulate and kind of fester in the area, which will cause the bone levels to drop here. Figure 34-16 shows some generalized bone loss. Okay, this patient has bone loss throughout the entire mouth. You can see that alveolar level, or that alveolar crest, is far below 2 millimeters of the CEJ. Down here on the mandibular arch, as well as the maxillary arch, we see a bone kind of deteriorating. It's well below that physiologic bone level, or where the bone level should be. Severity can be classified as either slight, moderate, or severe. Slight bone loss is about 1 to 2 millimeters of bone loss. Moderate bone loss can be thought of as 3 to 4 millimeters of bone loss. And anything greater than 5 millimeters is considered severe bone loss. This is measured by the clinical attachment loss, otherwise known as CAL. So this is the measurement of distance in millimeters from the CEJ to the base of the sulcus, or the periodontal pocket. Classifications of periodontal disease is based on the amount of bone loss, and periodontal disease can be classified as ADA case type 1, which is known as gingivitis. This is not really affecting the bone. Here, the gum tissue can be inflamed, it can be bleeding, but the patient has relatively healthy bone still. This is the best type of gum disease to have because it can be easily reversed with proper cleaning and change in habits such as regular brushing and especially flossing. ADA case type 2 is known as early periodontitis. This is where we have some mild bone loss in the areas. ADA class or ADA case type 3 is moderate periodontitis. And then type 4 is advanced periodontitis. So with type 1, this is known as gingivitis. There is no bone loss here with type 1. There is no change seen in bone when viewed on a dental image. The only thing that we'll notice here is bleeding and maybe some inflammation of the gums. Here with early periodontitis, we have some mild crestal changes, some very mild bone loss in this representation here. And we can kind of see some ditched out areas of the alveolar crest. It's not a uniform or solid line here. It's almost like a dipped out area. This is when the lamina becomes unclear and fuzzy and no longer appears to be a continuous radiopaque line, such as in this area here. Horizontal bone loss is seen more often with ADA case type 2s. Bleeding may occur with probing, or pocketing depths resulting from attachment loss may be present, and localized areas of recession may also be seen. Here we have an example of ADA case type 3. This is moderate periodontitis. So we have horizontal or vertical bone loss that can be present. The pattern may be horizontal or vertical, and the distribution may be localized or generalized. We also may have some furcation involvement. This is when the bone level is approximately 4 to 6 millimeters apical to the CEJ, or when the bone and the furcation is destroyed, a radiolucent area is evident on the dental images, such as what we see here. Recession, furcation, involvement areas, and slight mobility may also be present. So in these teeth, we may have some mobility. Okay, the teeth may actually be loose already because they're not very well anchored into the alveolar bone here anymore. With ADA case type 4, this is known as advanced or severe periodontitis. Here, the pattern of bone loss may be horizontal or vertical, and there is definitely bleeding on probing. This may be vertical, and the alveolar bone here would be more than 6 millimeters from the CEJ. Furcation involvement is readily viewed on posterior images in almost every tooth, so this would be a pretty severe case. There are some predisposing factors and local irritants that may contribute to periodontal disease. Elimination is important in the management and treatment of periodontal disease. Dental images aid in detection of certain irritants such as calculus or defective restorations. So the effect of certain medications, tobacco use, and conditions such as diabetes are all considered risk factors for periodontal disease. Calculus results from the mineralization of plaque. So when people leave plaque on their teeth and do not take it off, that soft, sticky stuff that we can sometimes scratch off with your fingernail, that actually becomes mineralized and hard, and it's something that needs to be scaled or scraped off the teeth. So it'll appear as a white or light area on a dental image. It most often appears as a pointed or irregular radiopaque projection extending from the proximal root surfaces. They almost look like little barnacles that we would see like on the side of a ship. They may also appear like as a ring-like opacity, a nodular image projection, or a smooth opacity on a root surface. So these are stone-like concretions that form on the crowns and roots of the teeth due to the calcification of bacterial plaque. So if you look on figures 34-28 through 34-32, we can see some of these examples of what radiographic tartar looks like. And so these are these little nodules or little barnacles that we see on the cementum. They're just kind of growing. This is all very dense calculus. Usually calculus that can be seen at all in a radiograph is something that is actually pretty severe, and it would look worse in the mouth or under the gum tissue. So these are some anterior teeth here. Here we can see below some kind of smooth like projections of some calculus. And then this is exacerbating this vertical bone loss that we see and around this canine here. Okay, some other images of radiographic calculus. We can definitely see lots of calculus down here on these lower anterior teeth. which is no surprise that this bone level has dropped well below that CEJ. The CEJ is way up here. Their bone level should be up here. And because of all of this tartar that has built up over the years, it has literally eaten away all the bone tissue. Here is a posterior tooth. We see these little nodules or barnacles on the side of the teeth here. That is all calculus or tartar. Same thing on this patient here. We can see lots of bone loss that is resulting from those pieces of tartar. This is a more advanced case of some lower anteriors. All of this kind of fuzziness on the cementum, that is all tartar. And so what has happened here with this patient, it has gotten to the point where just about all of the bone has been destroyed, which is supposed to be supporting these lower teeth. And because that bone is destroyed, we can see huge space that is developed between these central incisors. This patient is more than likely going to lose these teeth. Once they get to about this area here, these teeth are no longer savable, and we're talking about some type of dentures usually. Okay, there's another representation here. Here is some pretty advanced calculus. We can see some bone loss that is evident because of all that calculus there. So when we see images like that, it's usually not a good thing for the patient. Defective restorations are also a factor. That's because they may act as food traps and lead to the accumulation of food debris and bacteria. They may be detected both clinically and on a dental image. So dental images may allow for the identification of restorations with open or light contacts, poor contouring, uneven marginal ridges, overhangs, or inadequate margins. So we'll start with figure 33. So here is a representation of what restoration should look like. So you can see this patient has some pretty healthy bone level here. Also, these are some very beautiful restorations. We can see some nice smooth margins here. There's a very small food trap here, but it's not terrible. For the most part, the dentist did a pretty good job of making sure that these restorations are nice and smooth. The smoother the restoration, the less surface area that bacteria has a chance to grab onto. So this patient can very easily floss, and none of these restorations are going to cause floss to shred. And so they're going to usually, when floss doesn't shred or get cut up, when a patient is flossing, patients are more likely to get floss in and out of there more easily. And so for this reason, they have actually some pretty healthy periodontum there. Okay, here is when we see some defects with some crowns. So we'll start with this upper left picture here. So this is a very ill-defined crown or ill-defined margins. We can see some overhangs here. Right underneath here, this is a perfect floss, the shredder, I would say. Every time a patient would attempt to get floss through here, they'd most likely probably catch their floss on these overhangs here, tearing their floss. So I bet that they're not going to want to get floss through there very often. And because of that, we can already see some vertical bone loss around or underneath this restoration. Okay, here is a more exaggerated representation of an ill-fitting crown. It looks like, from the looks of this crown, this is one of those stainless steel crowns that come in basically generic sizes. They come in a box and they don't really fit any patient. They're usually more for pediatric patients where they're going to lose the tooth anyway. And here we can see some very severe bone loss. It's all the way around the furcation areas. There is literally nothing holding on to this tooth beside this small area around this distal root here. And it's because there's been so much bacteria that has probably gotten up underneath this crown and just kind of eaten its way through the periodontum. Okay, down here is the same thing. We have a perfect floss cutter here. Very, very poor restorations. There is literally no adaptation from the restoration to the tooth. It's very poorly done. Lots of bacteria can get through here, and it's just kind of exacerbating this bone loss. We see some very severe furcation involvement here. Lots of bacteria is getting underneath this furcation, where definitely not the patient and really not even the dental hygienist can get instruments underneath there to effectively clean that out. Okay, so here is another poor margin adaptation. Here, the dentist probably should not have restored that tooth if the decay was going to get so far underneath the tooth that it would prevent the patient from cleaning underneath here. So this here is not gum tissue, this is bone. This means that this restoration went all the way to the bone. So there is no possible way that a patient can get floss underneath there and effectively clean it out. So we can already see some signs of bone loss around or underneath those restorations. So that was it for chapter 34. Please let me know if you have any questions. Thanks for listening.